These are my financial disclosure. So this is a case of a 53-year-old woman with a history of herpetic keratitis and uveitis in the right eye, treated with oral antiviral, topical steroids, and topical IOP lowering agents, came for a second opinion from one of my fellows. And she had a Tmax of 48 prior to surgery. In 2014, she had an Ahmed valve. She's currently on mild, Predmild, Comigan, and Famvir. She is allergic to a lot of medications. She is a designer, well-known designer, so she doesn't want to use a lot of the drops. Her visual acuity is 20/25, IOP on medication 27, well-formed blip over the plate, mild stromal haze. The eye is quiet now, and she has +1 NS. Her corneal thickness is 548, gonioscopy totally open. So these are her visual fields, and you could see that there is progression on the visual field. You could see there is progression on the OCT. To the audience response. What would you do for this patient if you were choosing surgery? And we'll give it 30 seconds. Wow, that was good. Okay, so the majority, it was in between MIGS and second tube. 25% went for a trab. So let's ask the panel, can you, each one of you starting from the left, can tell me what would they do and why do they do it?
I think initially, I would agree with the second tube. However, I'd like to know a little bit more in terms of if the primary tube had been manipulated at all, had the plate been injected with 5FU, if that was a strategy, had there been a revision of the bleb overlying the tube. And then I think it's reasonable to consider an angle procedure to try to get filtration through the trabecular, as if we're already getting good flow through the tube itself. But a second tube was possibly going to be the option down the line.
To answer your questions, yes, it has been manipulated, not revised, but manipulated with 5FU.
With 5FU with not much response.
Yes.
Yeah.
Dr. Smith?
My option would be an angle-based mixed procedure. Just judging from the patient's history of having HSV, it's keratitis, I want to suspect that the reason why they have elevated pressures as a result of the steroid response, and I realized that doing trabecular stripping type procedure would be very effective in lowering their intraocular pressure. So a trabectomy or GAT is possibly what I would do here.
Dr. Parrish?
I wouldn't do any of them. I would do a limited cyclophotodestruction, perhaps 30%, 40% of the angle, with the notion that you could do additional procedures as need be. Mother Nature abhors plastic. The eye is already inflamed. I think the likelihood of a second tube having a profound pressure lowering effect is small, so I would not elect any of the procedures listed.
Yeah, I agree with Rich. I think the cyclodestructive procedures you would think that they would do poorly in people who are prone to uveitis or actually have prevalent uveitis. But actually, I've not found that. I think that they don't really get any more inflamed than anybody else does, nor do they get more inflamed or cause more inflammation than other procedures in the context of uveitis. So I've been very happy with cyclodestructive procedures in an adjunct to a failed tube in this group, and I'd probably start there.
Who am I to disagree with these two gentlemen? I actually like that option, a limited CPC. We can do it in a more ginger fashion than we once did 15 or 20 years ago, and I think it's a nice option. Second to that, I probably would put a second tube, but there is some room here, and you could test the hypothesis about the steroid response, because I believe they're still on steroids, so you could think about stopping the steroids. You do get steroid response even with a working tube, and so it's an option, but I think CPC would be my knee-jerk.
So for the people who are saying CPC, you're not worried that there's increased inflammation after CPC and what is going to happen to the uveitis? This patient is chronically on steroids because if you stop it, she gets inflamed again.
I mean, I've probably done a dozen of these, and I've not seen any worse inflammation postoperatively than I have with any other procedure.
Joe?
So I actually agree. Initially, when I looked at the choices, I thought I was going to go down the second tube route, but when my mentor, Dr. Parrish, says not to do that, I am not one to disagree. So I definitely agree that CBC does work well. I tend to prefer it as an adjunct after someone's had a Barvelt implant, but there's no reason it won't work just as well when somebody's had a prior Ahmed implant. And I agree with the rest of the panel. You know, you just alter the way you go at it. You probably will do a half treatment. I would do traditional transscleral laser, about 10 to 12 spots along the inferior quadrant, and make sure that I do give some bolus of steroids after the procedure. But I do think that's a really nice option here.
I know if you are going to, because of what Dr. Walton has presented in the past, that angle procedure is the best way to go in uveitic patients. Do you do it as a primary procedure now or not?
I think actually that would have been really the more interesting question, or an interesting question would have been, what would your primary procedure have been for this patient? And I think if I had seen this patient initially and there was not a prior Ahmed tube shunt placed, I would have considered doing the GAT procedure.
For the people who do GAT, is there more inflammation in uveitic patients or not?
Typically, if I was to do a GAT in a patient with uveitis, I would wait for the patient to be quiet. So I do it in patients who have uveitis. It is actually right now my preferred procedure in people who either have a steroid-induced elevation in intraocular pressure, or people who've come after getting an anti-VEGF injection of some sort, and it works really well.
The patient being phakic, does that affect your decision or not when you're doing GAT?
No. For me, because of the pathophysiology of their glaucoma, especially as we have described, it works well. The other thing to remember about this patient is that looking at the GAT results, patients who have had prior tube shunts actually do really well with the GAT procedure in the patients that were studied in the initial study that we had out.
Okay, can you show the slides? So this patient actually was done by one of my fellows, so usually we open 2 clock hours, and she had trabeculectomy with mitomycin C. The patient is very happy. It's 4 years later, and her pressure is 8 to 10 on no glaucoma meds, just mild bread. Her visual field and OCT have been normal. Does this result change any of your decisions or not? Okay. Can we put the questions again for the audience, the same question, and let's see their response to see if the panel changed what you think. The results? Perfect. Thank you.